Okay, I think we better start. So hello everyone. It's so nice to see so many names kind of flooding in there. So I'm very fortunate tonight to be joined by Katie. Katie's a pelvic floor physio down in Mandurah, so some of you will know her for sure. So tonight I'm hopefully just going to speed through my presentation and just give you an idea of men's health and what we can do. And then I'll hand it over to Katie to talk all things pelvic floor. And if you've got any questions, please put them through the Q&A box. It is anonymous. No one can see that you've put the question through, only us. And hopefully we'll get to answer them as much as we can. This is going to be recorded, so if you want to go through it again, you're more than welcome to rewatch it. So once the recording is done, it'll all be emailed to you to watch, and I'll also be putting it up onto the YouTube channel so that you can watch it a bit later. Alrighty, so I'm going to share my presentation. Oops, press the wrong one. Hang on, sorry. Try that again. Okay, that's all good, Katie. Just double checking you can see what I can see. Great. Alrighty, so welcome to Men's Health Matters. So I'm Kendall Gow. Nice to meet some of you that I haven't met before. And of course, that's Katie. So erectile dysfunction is defined as the inability to get or maintain an erection that is sufficient for satisfactory sexual performance. So it's important to understand that erectile dysfunction is very common and it can affect men at various stages of their life. So in fact, 50% of men report experiencing some intermittent episodes of erectile dysfunction at some point during their lifetime. This means it's not always a chronic issue. Many men may face it due to stress, fatigue, or other temporary factors. The prevalence increases with age, so we know from about age 40, 40% of men will have some erectile dysfunction, and this prevalence increases by approximately 10% with each passing decade. Erectile dysfunction isn't just a sexual health issue, it can be an early warning sign of silent vascular disease. So research has indicated that erectile dysfunction often precedes heart attacks from about 2 to 4 years, making it a potential early indicator of cardiovascular problems, so anything related to the heart. This is why we say heart health is heart health. So the vascular system involved in achieving an erection is the same system that supports your heart. So if blood flow is compromised or blocked in one area, it may be compromised elsewhere. So erectile dysfunction can be a symptom of an underlying condition. So we might see men who have pre-diabetes or diabetes or insulin resistance. It might be low testosterone and, of course, high cholesterol. So when we look at erectile dysfunction, we're not just looking at the penis, we also need to look at the whole person sitting in front of us. So the penile artery is significantly smaller in diameter compared to the other major arteries in the body, as you can see. I know these funny little pictures are insignificant, but it's just to give you an idea of, the size that we're looking at. So like the coronary artery, the carotid artery, which is the one in your neck, and the femoral, which is down in your groin area, if there's any blockage or compromise or buildup of plaque, the penile artery is likely to be affected earlier, as I mentioned. So this is why if a man walks into a clinic and he complains of fairly sudden erectile dysfunction, this is a big red flag for further investigation. We need to know what's going on with the heart. So when we talk about an erection, we need to actually understand the pathway. So how does an erection actually happen? So you've got to have that sexual impulse. So when a man is sexually stimulated, so whether that's mentally or physically, the brain then releases a hormone called dopamine. That's your reward hormone. And this is very key that drives sexual desire and arousal. This then initiates that signal to go all the way down the spinal cord, and it goes into the pelvis to the pelvic nerves. In response to that, the penile tissue then releases nitric oxide gas, which then stimulates and relaxes the smooth muscle in the penis, and this causes them to dilate. This allows a significant amount of blood flow, and what happens is the blood comes into the spongy tissue, basically, and this fills with blood, and this compresses the veins to hold the erection, and we call this venous occlusion. And this venous occlusion is very important because it traps the blood inside the penis. That trapped blood then causes penile rigidity, which we all know as an erection. So when we talk about this venous occlusion, it's not just thinking about the blood flow that comes in. We do need to prevent that blood flow from escaping. And I'll talk about that a little bit later. So sexual dysfunction has many causes. We tend to call it multifactorial. So we can look at it as a disease process. So if someone has a medical condition like diabetes or heart disease or hormonal imbalances, they might even have neurological dysfunctions. This can all affect erectile function. The other one is treatment of the disease. So when we're treating things like diabetes or prostate cancer through surgery or radiation or medications related to the heart, so heart disease or blood pressure, they can also worsen sexual function over time. And of course, we need to consider the social and relationship factors. So if someone is under psychological stress, or they have anxiety or depression, or there's some sort of relationship breakdown, this causes a fight or flight response. Your body releases adrenaline, and we know adrenaline wants to get you away from the situation. So things aren't going to work as well as they should. So when we look at the management options of sexual dysfunction in men, there's lots of stuff that we can use. So of course, we will always try and tackle the psychological impact. So if there is stress or poor sleep or relationship difficulties, it might even be performance anxiety, then we can look at strategies to overcome that. Of course, lifestyle modification, that's super, super important. So if you're carrying a little bit of extra weight, or you're a smoker, or you drink alcohol too much, of course, we need to fix that. I'll talk more about oral medications tonight and injectables. You can certainly use vacuum erection devices, so these are your penis pumps, but just remember they are only really useful for penile rehabilitation, so when you're doing exercise for the penis. In terms of creating an erection and getting a sufficient erection with a vacuum device, it can be a bit tricky because the rings tend to slip and move, and a lot of men talk about it makes like a bit of a hinge effect. So they're good, but not as good as what they're sold to be. So they're good for exercise. Traction device. We can use a traction device called a Restorex, and this is more typically used for men who've got Peyronie's. So this is when you've got a funny angle or a bend in your shaft. So we can stretch them out and try and fix that curve. And if all else fails, then of course we can do surgical options. And this is the last resort. So this is when we put an implant inside to try and fix the erectile dysfunction. So lifestyle is very important. So while erections are primarily vascular and neurologically driven, so that brain stimulation, testosterone also plays a very supportive role in maintaining that nitric oxide inside the penile tissue. So men, only 1 in 4 men are not overweight or obese in Australia at the moment. And so obesity is associated with a higher risk of heart disease. We know it causes erectile dysfunction, type 2 diabetes, and about 40% of cancers are related to being overweight. So talking more about that low testosterone. So low testosterone can impair the ability to achieve and maintain erections. And why you get lower testosterone is because all that fat tissue converts the testosterone into estrogen, which is not what you want, and it prevents further testosterone from being made. So no, we don't give you testosterone in this scenario. The best thing to do is weight loss. And so for every 16 kilograms of weight gain, you lose penile length. So of course, any sort of weight loss is going to be the best thing that you can do. So a little bit about prostate cancer treatment and why there is some erectile dysfunction related to this. So when we talk about potency, this is just referring to the man's ability to get and keep an erection that is adequate for that sexual activity. So when we look at studies, whoopsie, bumped that, it's important to understand that there is a lot of variation in terms of erectile function recovery post-surgery. So at 12 months, we might see 54% to 90% regain. At 24 months, we might see 63 to 94% regain. Shortly after radiation treatment, we do still see erectile dysfunction. So I might see young men who come into the clinic and say, I'm only 53 or I'm only 63. I'm going to go with radiation treatment because I want to preserve my sexual function as much as I can. But we see this anyway. So we do still see erectile dysfunction at about 40% to 62% within the first 2 years post radiation treatment. So it does tend to get affected. And the chances of recovery, of course, is always going to be due to your pre-operative function. So when you meet me or when you meet a pelvic floor physio, we'll ask you, how are your erections now? How have they been working? Do you need medication to assist with anything? Because that's going to tell us how your outcome is going to look. And of course, surgical experience. So if you've got a really good surgeon, they're going to save all those nerves as much as they can. But still, we just don't know how you're going to turn out after that treatment. So why does erectile dysfunction happen when you have a radical prostatectomy for prostate cancer, so surgery or radiation treatment? So I know there's a lot of words on that screen, but basically when we talk about the proposed mechanism behind the erectile dysfunction, it's not just a single issue. So it's related to the nerve damage, the vascular damage, and of course the tissue. So even though we have good nerve sparing techniques, there is often some degree of injury to that cavernosal chambers, that spongy tissue and the blood vessels, and of course that smooth muscle. So these structures are very critical to initiating and maintaining that erection. So after surgery, due to that reduced nerve signaling and blood flow, the penis experiences what we call a state of hypoxia or very low oxygen. So that tissue is just not getting enough oxygen anymore. So this hypoxia then stimulates all these sort of growth factors, and this promotes scarring. So this is why we do that penile rehabilitation, to force that blood flow into the tissue, to stretch it out and get oxygen into that area to prevent this from happening. It's also because men lose their nocturnal erection. So your body would take the penis to the gym 10 to 30 times during the week, in the middle of the night and first thing in the morning. And that's to keep that blood flow and oxygenation going. And then we see a suppression of this PGE1. And this is called a prostaglandin, which causes that vasodilation. So when we lose that, again, we're not going to get that oxygen-rich blood flow into the area. So when we don't do anything after surgery or radiation treatment, because I do get asked that a lot by men, what if I just do nothing? We might see this veno-occlusive dysfunction. So remember, when that blood flow comes in, those vessels are meant to shut and hold the erection. They become floppy and they open up, and so you don't get enough blood flow coming in. That's going to be stopped. It starts to pass out. We also get reduced penile weight and volume, so there might be loss in length and girth. And so we do know that there is about a shortening of 1 to 4 centimetre loss over time. So when we talk about penile rehabilitation, we're looking to prevent that smooth muscle damage. We want to re-engage in sexual activity as much as we can. and try and re-establish or maintenance of that intimate relationship that we have. The protocol, of course, is always going to be individualized to every different man. We all have different backgrounds. And the aim of the treatment is if we don't use it, we can potentially lose it. So let's talk about the medications, because that's what most people are interested in. So we've got lots in Australia. They're all relatively cheap now because they've come off patent, but the most common ones that most people know are Viagra, which is sildenafil. We've got tadalafil or Cialis, Levitra, which is vardenafil. We do have that, but it's very difficult to get your hands on, so you won't see it very commonly. It's the more potent of the actual medications. We've also got Avanafil or Spedra. So we call it Speedy Spedra because it's the quickest one on the market. So if you compare that to Viagra or tadalafil, they take about 30 minutes, sometimes up to 2 hours to work, whereas Spedra is about 15, 20 minutes. It is still a little bit more expensive at about $40 to $60 for a box of 4. But if you're not getting as good a result with Viagra and you try that, you pay a bit more money, it's not going to give you a better effect. The newest one that we have on the market is called Spontan. It's a nasal spray. And with this medication, it's only accessible via the TGA. So if you wanted it through me or through a GP or someone, we have to apply to the TGA. And we say this patient would like this medication, basically, and then they approve it. It's quite a simple process. Because what this medication is that vardenafil, that one that you can't really get your hands on. And so they've made it a very small dose. And so when you spray it up your nose, you don't need as much as when you swallow a pill, because that's got to go through your digestive tract and work its way to get it to work. It's very expensive at the moment. So you're looking at about $240 to about $280 to get it. And you only get 17 treatments. And it's very important that you spray it in the correct way. So you've got to blow your nose, you've then got to sort of prime the spray bottle, tilt your head forward, close one nostril, spray it up one, close the other nostril, spray it again, and then block your nose. And you've got to try and not sneeze. Now, the feedback that I've got from men on this medication is that the burn and the tingle can be quite significant for some, and then some of the other men, they've gone, yep, I did notice it, and I just had a runny nose. It wasn't too bad. It's very exciting that we have this medication. It's just another tool in the toolbox. And so whenever men sort of ask me if they want it, I'll absolutely prescribe it. But if you are someone who's using a very high dose of injections, or you've got very significant to severe erectile dysfunction where medications or tablets aren't working, then this probably won't work. But I'm always an optimist where I'm happy to prescribe the medication if you wanted to try it. So it is readily accessible through pharmacies, but we still have to apply to the TGA for you to get access to it. So moving on to injections, never a dull moment when I mention these in the clinic. You know, men sort of look at me with very bright eyes going, oh, don't tell me I need to put a needle in my penis. But to tell you that it is very safe to inject, it's very reliable, and the onset of the action of the injection is very quick. So for some men, it might take 5 minutes, and some it might take 20 minutes, and that's normal. It's very localized. So if you've got men who are on particular medications for their heart and they can't take medication like Viagra or Cialis, this can still be taken. It is safe. It only works in the penis, nowhere else in the body. So you won't get a headache. You won't get redness in the face like you may do with Viagra and Cialis. The only negative with this is that you've got to stand in my room and we've got to do the injection together. So I have to teach you how to do it, because you need to see where to put the injection, and then we need to work out what the response is. The biggest complaint that I get with injections is that it's a bit more planned. So it does interfere a little bit with intimacy, but this is where you kind of have to build it in, you know, especially if you've had your prostate removed for prostate cancer. or radiation treatment for prostate cancer, where you've got pretty severe erectile dysfunction, the script has to change. We have to build this in. This is the only option that we have. Occasionally, it may be painful, and the reason why that might happen is it's just technique. So if you've put it in slightly wrong, so as you can see on that picture, it's always on a slight angle at 10 or 2 o'clock position, or there is a particular medication that we can use for this that may cause a bit of a shaft ache. That's kind of how men explain it. So I kind of pick the one that doesn't cause pain versus the other one. And the biggest problem is if you've got a big belly, you can't see your penis, and so doing the injection is a bit difficult. But I've taught many partners on how to do the injection, and it works pretty well. So there are 2 different types here in Australia. So we've got Cavaject. Cavaject is also around the world. So this has to be mixed. So it has like a water mixture in there with powder, and you kind of just got to mix the 2 together. Alprostol is that medication that can cause pain. So men say it feels like a very strong, dull ache in the shaft. It's very expensive. So you're looking at about $25 to $35 per injection, and it's 1 injection only. It's 1 use only. And it only comes in 2 strengths, so either 10 or 20. So if 10 or 20 micrograms doesn't work, that's it. You're pretty stuck on that. It's very difficult to get your hands on now. There's not many pharmacies that hold it for some unknown reason here in Australia. So the most of us that do this, we use a compounded mix, which means that we've got to do a bit of a trial process to make sure that it's safe and adequate for you to use. It comes in different mixes, so you might get a 1 mix bottle, or you might get a bi-mix, so there's 2 different drugs in there, or a tri-mix, 3 or 4 mix. It's cheaper long term, so the actual vial only costs about $140, $150, and you'll get about 20 injections out of there, and it just stays in the fridge. And we can always just do dose adjustments quite easily. So the biggest concern when I see men is a priapism. So priapism is when you have a prolonged erection. It's very painful and it lasts more than 2 hours. So when I do this process in my clinic, I make it very, very clear on how to treat this and to contact me if it doesn't go down. It's very rare, but of course it can happen. And the reason why it typically would happen is the first dose that I do with you in clinic may be too much. I'm a nervous Nelly, and so I always go as low as I possibly can. Sometimes it's just a bit stronger than I expected. If you try and do a top-up dose, so I've had men who've done injections and then they've given themselves a little bit more because they just want to be a little bit harder, or they've done 2 injections in the 24 hours. You can only do 1 in 24 hours, or they've given themselves too much. The other time I might see it is if they've tried to mix it with a PDE5 inhibitor. So that's Viagra or Cialis, that's a big dose. And so if they've taken it at the same time with the injection, or sometimes they've taken that tablet 24 hours before the injection, and that can have a prolonged effect. And the biggest one is nerve function. So if you've had a radical prostatectomy, had your prostate surgically removed, we may see those nerves starting to work and they might interfere, which is quite exciting. But of course, a priapism isn't fun. So common misconceptions around injections: it doesn't work. Very rare that I would see that it doesn't work unless you've got that vascular occlusive disease. So that's when you get floppy valves. So remember that blood flow needs to come into the penis and stay there. If you've left your erectile dysfunction for too long, of course, age will have some impact, but otherwise it's very rare that it doesn't work. What if it doesn't go down? I've heard horror stories. Of course, there's going to be lots of horror stories out there, but again, it's very rare. This is usually poor management by the patient themselves or by the practitioner that has given the medication and not really done much follow-up. It causes damage. Again, this is user error. So if you're constantly injecting incorrectly or you're injecting in the same spot over and over, this is going to cause scarring. And so yes, we might see a bit of curvature changes there. The other one, I heard it's painful. I don't want to put a needle in my penis. Again, we need to know what medication was used. And more often than not, I would honestly say 9 times out of 10, men go, oh, Okay, that wasn't as bad as I expected. So it is a good drug to use if you were looking at that. So that's me done. So I'm going to hand over to Katie to talk all about pelvic floor.
Fabulous. So I'm just going to get my presentation up. Just bear with me 2 seconds. There we go. Is that looking okay, Kendall? Fabulous. So tonight I'm going to be talking about pelvic floor muscles and male sexual function. So what is the pelvic floor? The pelvic floor is a sling of muscles that comes from the pubic bone at the front through to the tailbone at the back. And it has multiple jobs to do. So first of all, it controls the flow of urine and feces. It has a role in sexual function, which is our focus tonight. It supports the pelvic organs, so it holds your bladder, your bowel, and everything inside that pelvis. And it has a role in that postural support, working with the back and the abdominal muscles. So when we look at the male pelvic floor, we start to separate it into layers. So we look at the deep pelvic floor, which is the pelvic diaphragm, and we call these muscles levator ani and coccygeus. So you might see those words come up when you're doing research on the topic. We then have the middle pelvic floor, which is the urogenital diaphragm. And here we're talking about what we call the superficial and deep perineals. And then, of course, the superficial pelvic floor, which is the outermost layer. We're talking about two really important muscles in sexual function, ischiocavenosus and bulbospongiosus. Now, we don't expect you to remember these names, but it's what they do that's important. So I've just put in this diagram just basically to indicate that these are showing two different layers, okay? And we've got complexity. It's not just one muscle. They're different muscles that combine with different attachments and have slightly different roles, whether it be through that maintenance of continence or sexual function. Now, I just want to, I don't know if you can see my cursor, but on the first diagram, we can see that we've got the shaft of the penis here. And then we're looking through here. This muscle is bulbospongiosus. So as I said, that's quite an important one for us to remember in sexual function. And then off to the side here, we've got the ischiocavenosus muscle. And it's coming in, we've got the bulbospongiosus attaching to what we call the perineal body, which is a really strong support in the pelvis. And then we also have that ischiocavenosus coming out to where what we call your ischial tuberosities. And that is basically your sit bones. So they have a really important role, as you're about to see. So we've got to look at how does this all work? So when you're having sex, you need to be able to keep that urethra open to make passage for your ejaculate. So that word, the corpus spongiosum, that's the spongy tissue within the penis that we've been talking about through Kendall's presentation, and the corpus cavernosum. And that tissue holds 90% of the blood during an erection, okay? So let's then talk about that ischiocavenosus muscle, the ones coming out the side and attaching and anchoring to your sit bones. So that weaves around the base of the penis and extends out. And then you've got the bulbospongiosus at the base of the penis, holding it in and in the middle straight. So connecting to that perineal body. So essentially these are anchoring the penis and stabilizing it during an erection. Okay, we don't want the penis to be moving everywhere. It needs to be nice and stable. So that's how it has its contribution to initiating and maintaining erections. Okay, and that bulbospongiosus muscle at the base of the penis also helps to empty the urethra at the end of urination, and it helps with expelling that semen during ejaculation. So we look at 4 phases of male sexual function, and some of these we've already discussed with Kendall's presentation, so I'm not going to go too far into it. But desire, we have to have desire for sex to start with for both men and women. And that involves a lot of, as Kendall said, there's psychological aspects to them. We look at stress, and all those things can impact desire. But if you're having continual issues with sexual function, that in turn can affect desire as well. We have erection, then ejaculation and orgasm. And then after that, we have flaccidity, which is that determiscence, basically, which means the end and you lose that erection. So we've talked about an erection, and I've put a really great fancy description there, but we know that it's about maintaining that erection and being able to use it for sexual intercourse. Okay. So for an erection, ischiocavernosus contracts. Okay. So it increases the pressure at the base of the penis. Bulbospongiosis contracts and it creates that engorgement of the penis, and it kind of acts as a backstop. So it helps to block in the blood and stop some of that seeping out. So it contributes to increasing that pressure. So then we talk about ejaculation, and that's a muscular event. So you get contractions along the smooth muscle of the penis, the muscle of the bladder, and the muscle around the prostate as well. Okay. And all at that same time, the little muscles around the urethra, your urethral sphincter muscles, have to relax as well. During ejaculation, you get those strong involuntary contractions of that bulbospongiosus muscle. So it's expelling that ejaculate along the penis and creates that pressure to help move it through the tube. So this causes the prostatic and the seminal vesicle fluid to move through the urethra under that pressure. So if we look at different types of sexual dysfunction, we've got erectile dysfunction, which Kendall has talked to us about in quite a bit of detail already. We've got premature ejaculation. So that's ejaculation that occurs prior to or within about a minute of vaginal penetration, or that inability to delay ejaculation. But we've also got pelvic pain syndromes. So persistent pelvic pain is always, we always call it in the absence of proven infections or other pathology. So if you've got a cancer, if you've got an infection in your bladder, we need to treat that first before we try and treat pelvic pain. So pelvic pain syndromes are often associated with negative thoughts, changes in our behavior, whether it be sexual or emotional, and often is associated with other symptoms such as bladder dysfunction. So whether that's going to the toilet frequently, having urinary incontinence, or just needing to go to the toilet suddenly and really quickly. And it can also have bowel consequences as well. So that might be that you become more constipated, that you have pain opening your bowels, that you have fecal incontinence. And so as a pelvic health physio, our role is to assess the whole you. We will go through psychological factors and social factors, and we will also go through bladder, bowel, and sexual dysfunction in quite a bit of detail, because it's important we put the picture together in how these structures are interplaying. So when we look at the pelvic floor muscles, I always have to ask, too weak or too tight? And most people think that their pelvic floor is always going to be weak, and in a lot of cases it is. But when we're talking about tight pelvic floors, it can contribute to pain. So I want you to think about if you squeezed your fist as hard as you can and you kept it squeezed for the next hour, and then you tried to open your hand, it would be really difficult and tight and sore. And that's what can happen to your pelvic floor, especially if you've had surgery. So for prostate cancer, some men come out and they've had their catheter in, And the response of their body is to hold on tight because essentially it's been pushed and poked and prodded in this surgery and it's trying to recover. So its method is to protect, tense everything up, let's protect the body. But that becomes non-useful over time. But in both cases, if that pelvic floor is just weak and floppy, or if it's too tense and won't let go properly and won't contract properly, then you're not going to get it working effectively for sexual function, for bladder function, or for bowel function. So a lot of people ask, well, what are you going to do? And because the pelvic floor is in such a delicate place, a lot of people don't want to come to physio because they don't want to talk about it. They're like, how are we going to work? Am I going to have to get my clothes off? The bottom line is you don't have to get your clothes off if you don't want to. Okay, we have lots of different strategies within pelvic health to help teach pelvic floor training. So for a weak pelvic floor, we're going to work on that pelvic floor muscle strength. So the first thing we'll do is pop you on that ultrasound, get a picture of that bladder, and we'll watch that bladder base move as you activate your pelvic floor and see how it moves. How long can you hold it for? Do you have good coordinated contractions when we go fast? What happens when you cough? What happens to the quality of that movement as you start to fatigue? The other thing that we'll talk to you about is general exercise. So, are you doing some sort of cardiovascular exercise? Do you go for walks? Are you a swimmer? Do you cycle? Because if you're not fit, it's really hard to be fit for other activities such as sexual function. And when we do cardiovascular exercise, we're looking after the heart, we're looking after the lungs, we're moving that muscle, and we're getting blood flow around the whole body. We're also going to look at that whole body strength and endurance because we know when the muscles surrounding the pelvis are strong, it allows that pelvic floor to do its job instead of being overloaded because other structures are weak around it. So let's look at what if you have a tight, tense, or painful pelvic floor. Well, once again, we're going to assess on an ultrasound to start with and look at that movement of the pelvic floor and see, is it really stuck? Is it small movement? Does it not let go properly? And that gives us a bit of an idea. It's not fully diagnostic, but it gives us an idea. We're going to teach you how to relax those pelvic floor muscles. We're going to use breathing techniques and some visualization techniques to show you how to lift and let the muscle go and to increase that range. We're going to do stretching because we know if we can stretch those muscles around the hips, it can have a really nice flow into the pelvic floor to get that to relax. We do lots of different movement and remapping exercises to retrain that brain how to let that pelvic floor go in multiple positions. It's all good to practice laying down, but if your problem's standing up, we've got to take that practice a position that you're having the issues with. Now, pelvic floor releases are something that can be done, and this is usually an internal type thing. So I'm talking about rectal assessments, and physios who are trained can do these. And what we would do is be very selective with how we did them, and it's always based on consent from you. If this is not something you wanted to do, you don't have to do it. There are other things we can do as well. But I think it's important that people are aware it is a skill that we can do and it can be useful for a lot of men. So releasing that pelvic floor, massaging it, getting it to let go. And regular exercise once again, walking, swimming, yoga, gym, anything that just gets that gentle movement of the body. It doesn't have to be a hard workout. Flowing, easy movements can help let that pelvic floor go. When we assess, as Kendall alluded to before, we like to treat the person as a whole. So we would have done lots of assessment looking at whether psychological and social factors are a contribution to this. And if they are, there's some whole body strategies that we can start to include in your physio program that helps to calm that nervous system, which in turn can reduce a bit of that feedback into the pelvis. Another really important thing with sexual dysfunction for both men and women is to look at sexual intercourse or foreplay. It is really important during that time when, things aren't working so well and you may not be able to have penetrative sex, that you can still maintain that relationship and that sexual connection with your partner, but also to keep your brain understanding that you're in a safe place and that sexual function is enjoyable. So anything that is kissing, touching, all those kind of things that are fun and enjoyable and bring you closer to your partner, they're all really important activities. And I like to set that as homework, as a reminder to people that there are other ways of getting enjoyment. So I think the bottom line that we've sort of found from both presentations tonight is that sexual dysfunction is really complex for some people. So we've got psychological and biologic causes that can be involved. And as I said, it can come from nerves, it can come from blood supply, it can come from pelvic floor dysfunction. It all has to match up together to work. And I think that's really important in that men with sexual function dysfunction should have a team approach to this. So we're talking about having a nurse practitioner or sexual health practitioner like Kendall on board to look at those medications and look at those injectables. A urologist is sometimes required to clear other things and make sure there's no sinister pathology that could be contributing. We use psychologists and sexologists to help as well. It's important your GP is aware because, as we know, it can indicate other health conditions. So having your GP aware of your sexual dysfunction is so important. And then, of course, you've got your pelvic health physiotherapist. And I understand it is really hard to know, well, which one do I go to? It's probably not the best thing to go down to your regular physio down the road. Okay, you need to look for someone who's done that extra training in pelvic health, done a master's, and they have that extra training to help you understand what your pelvic floor is doing and how to differentiate all those different symptoms and make those connections to develop a treatment plan. So, basically, we'd like to throw it out to everyone. If there are any questions, please put them in the little box that is down below. I'm just going to unshare my screen. Let's stop share. So the Q&A box down the bottom, I see there's a few questions in there already, but please throw any questions you'd like at me and Kendall. We're here to help tonight and it's a great opportunity.
All right, so we might as well kick off with the first one in the Q&A
Yeah.
box. So how to do Kegels or pelvic floor exercises for men properly. This patient has tried lying on the floor and lifting groin to supposedly strengthen my muscles, but after doing it for the last 8 months, I still cannot stop leaking just before I get to the toilet, and it's really embarrassing. Is there any other way to do them? For example, standing or sitting?
So what we know is that 50% of people are doing their pelvic floors incorrectly, just from reading like a manual or something online or a pamphlet. So what I'd suggest is if anyone's having trouble with their pelvic floor and not getting progress with their symptoms, seeing a pelvic health physio is going to be a really important first step so that they can go through and look at not just the pelvic floor, but we will look at your fluids. We'll look at the frequency of urination and the urgency symptoms around it, the triggers, and there are some specific bladder training strategies that might need to go with it. But we'd be able to put you on that ultrasound and assess if you are actually getting that pelvic floor lift and release, and if it's adequate. So remember, it's all good to be able to lift and let go your pelvic floor, but if it doesn't happen quick enough, you might already be leaking. And if you don't have that endurance for that pelvic floor to last all day, you might find that by the afternoon, your muscles fatigue and then you start leaking more or you become more urgent to get to the toilet. Often what can happen in some of these situations, especially when you've had a catheter, when you're still recovering or your nerves are starting to recover, is you get some sensitivity around the bladder neck and in the urethra. And those sensitive cells can be the trigger telling you you need to go to the toilet. And we know that that pelvic floor has a really close relationship to those muscles of the bladder. So, for instance, when you don't need to wee, the pelvic floor is contracted at a baseline level at rest, and your bladder muscles are nice and relaxed. So, it stores and can fill without leaking. But when it hits a certain pressure, it signals to the brain, and the pelvic floor then relaxes and the muscle of the bladder squeezes. If you don't have that coordination because there's super sensitivity and those alarm bells are going off way too early, then we need to retrain. And usually we'd start you off with a bladder diary and put some of those strategies in place once we know how your bladder's behaving. So for that particular scenario, there may be a little bit more than just pelvic floors that need to be addressed. But pelvic floors can be done in any position. You can do them standing, sitting, laying on your side. But as I said, depending on what your symptoms are, if your urgency is happening when you're standing, trying to get to the toilet, we need to make sure that your pelvic floor are effective in the standing position. But the best advice I can give this person is to definitely find a pelvic health physio. If you're not sure of someone local to you, please feel free. Our details are at the end of the presentation. Email us, we'll find someone who's close to you.
Right, thanks, Katie. I've got another question here through email. So one of them is the pros and cons of nasal spray versus oral Cialis and Viagra. So the pros and cons of the nasal spray, which I kind of alluded to, the pros is that it's working within about 10-15 minutes. So that's why it's called spontan. It's spontaneous. And you deliver it to the nose. So the absorption is very quick and you don't get the side effects that some men might experience, like flushing of the face or headache, or some men say they just feel very hungover once they've taken the medication. So that would be sort of the pros and cons. The other con of the nasal spray is just the expense. So if you've got $250 and you want to spend it, please do. You're more than welcome to, because it's a nice medication to try. But Viagra and Cialis are very cheap now. They're both off patent. You can get a box pretty cheap for about $30, if that. The other question is effectiveness of the nasal spray, costs versus oral therapy for erectile dysfunction, post-prostatectomy in conjunction with pelvic floor therapy. So typically after, the prostatectomy, we would be prescribing these medications, oral, to get that blood flow going there. Any sort of relationship there, Katie, with the pelvic floor and being on these medications?
Look, I think with medications, we're looking at that team approach. They have benefits. And if you're not getting that blood supply in, working the pelvic floor, you need to have that pelvic floor working with the blood supply. So it's a delicate balance between all aspects. So I think it's really important that you can't just do one or the other, that you have to have everything. You have to have blood supply, nerve supply, and pelvic floor working in coordination together.
Right. All right, so another one, because there's a few questions to get through. So where is seminal fluid stored before sexual activity? So seminal, as far as I'm aware, seminal fluid isn't stored. So basically the sperm, if you haven't had a vasectomy, travels up the epididymis through the vas deferens, I think it was, going back to my biology, to the ejaculatory duct. And then as it comes up, it passes through the seminal vesicles, and that's when the seminal fluid is added. And then that mixture then travels through the prostate and then out it goes. So it's not technically stored before sexual activity. Yeah.
Can I address this next one?
Yeah, go for it.
So, someone's just put here, please tell guys that that they keep their pants on during a ultrasound for pelvic floor training. Absolutely, you do. Okay, I really want to emphasize that you do not have to get your gear off. We have ultrasound where we put the probe on your tummy and we get a picture of the bladder from your tummy, and we see that bladder base lift up and down. Some physios can do what we call perineal ultrasound, where they will put that probe underneath. It is another option. It does give a different view, which can be very useful, but you always have a choice. You don't have to do it if you don't want to. It is about your comfort. And we would rather you come and have the abdominal ultrasound, okay, and get the right exercises than not come at all. And this is very important. You do not have to have a rectal. You do not have to get your gear off. You can keep your pants on. It is really important that if you need help, we've got options. If we find that you're not making progress, we'll give you the option. We'll say it's up to you, but if you'd like, we can try these other methods. You don't have to accept that either, okay? We will be flexible, and most of the time, I do not have to do any invasive assessment, okay? I've probably in the whole year only had 2 that have not progressed. So I have done 2 rectal assessments in this whole year for men. That's how infrequently it happens. So please do not think you have to get your gear off. You definitely don't. It's just an ultrasound on the tummy. And I hope that clears it up for everyone.
Right. So another question. So post-radical prostatectomy, taking Cialis daily and nocturnal erections are gone or reduced. Is it better to take Cialis at night or in the morning? That's a great question. So yes, you may see more activity at night if you take the medication at night for sure. But again, every man is so individual. They might prefer to take it in the morning with breakfast. Or they might prefer to take it at night because that's when they remember it. But in terms of the absolute evidence, I don't think it really matters all that much. But I do know men do report they'll experience a lot more erections overnight if they take it at night time. I'll quickly jump to another email one. So can select specialist compounding pharmacists compound 5 milligrams and 20 milligrams Cialis in increased amounts of current 4 in a pack, and at what cost? Yes, there are compounding pharmacies all around Perth that do make these medications. It just won't be 5 milligrams or 20 milligrams because they can't replicate what's already on the market. So if I were to give a prescription, I would typically write it as 5.5 milligrams. That 0.5 is irrelevant. It's just so that they can make the medication of it. And so pricing, it varies. So there's a pharmacy near me who charges $120 for a box of 100. The one down in Mandurah, they only charge, I think, $75 to $90 for 100. Oxford Compounding is the most popular one here in Perth. They charge, I think, $95. And then there's one further north. They've charged $160 for a box of 100. They can't answer why that they charge that much, but you kind of need to shop around and see what sort of deals they'll do for you. Another question here. Just had an incisional hernia surgery, and since then my incontinence has returned. Yeah, we do see that. When sneezing and laughing, I can complete any exercise at the moment. Any suggestions?
So if you've had hernia surgery, it depends on how far post-op you are, but pelvic floor exercises should be relatively safe to start doing. Once again, I think going to someone and having an assessment, getting on that ultrasound and just seeing what your endurance is like. You're reporting at the moment sneezing and laughing, which is what we call stress urinary incontinence. So we talk about that closure of the urethra and the pelvic floor muscle, but also we need to look at strength. So is it strong enough to get that full closure when you cough or sneeze? So there's a lot of functional training that might need to happen. Sometimes when you have a surgery in the proximity of that area, you get pain and swelling, and that can be enough for the pelvic floor to kind of go, oh, there's something going on here and I don't feel great. And so it can get a little bit weak during that recovery time. But you should be able to get on top of it. But once again, as I said, it depends on how far post-op as to what exercises and positions and things like that, and the instructions of your surgeons. So if you've got those things, take them to your pelvic health physio and they should be able to help you to get started on what you need. But once again, it's not just about the pelvic floor. We've got to look at the other things like your fluids, your bladder habits, and all those sort of things too.
Great. Another one for you, Katie.
Yes.
Fit, is indoor rowing on a machine recommended, apart from doing regular brisk walks on a treadmill 9 to 10 weeks after a radical prostatectomy? Thank you.
Yeah. And so the simple answer to that is it depends on your symptoms and how good your pelvic floor is doing and how your abdominals are recovering. At 9 to 10 weeks, I see men with a huge range of symptoms. Some guys are dry already and they're having no issues, and some guys are still using 6 pads a day and needing a pad at night. And if you're one of those people who are still leaking and your pelvic floor isn't functioning so well, on a rower in that seated position, you might be increasing that intra-abdominal pressure a little bit more, and your pelvic floor, if it's not working well, won't necessarily be strong enough to work against that pressure, and so it could cause more leakage. So it's really dependent on your symptoms and where you are, at what stage you're at in your pelvic floor recovery. We want to encourage people to move because movement is the best thing. We know at 9 to 10 weeks, your surgical healing is very much sort of complete and stable. And so movement helps address scar tissue, but movement in general, it's just so good for our health that the the benefit far outweighs the risk, but we've got to select the right types of exercise. So what I'd be doing if you were my patient is going, right, have you tried the rower? Did you have pain? At what point did you start leaking? Was it straight away? Was it on the pull? Was it as you came back in? And if you didn't have any leakage at all, no worries. That's great. It's an okay exercise. But if you were leaking during that movement, I'd want to break that down and start to look at what's that pressure doing? Is this exercise just a little bit too soon for you? It's not a never exercise. It's just at what point do we introduce it, depending on your pelvic floor strength and coordination.
All right. Is there surgery available for persistent incontinence? Yes, there is. So there's different types depending on what the incontinence is looking like. So the first thing, of course, is seeing a pelvic floor physio, and if we're just not getting better, then we would typically do a process of elimination. So they'll do a test, it's called urodynamics. And so you'll have a flexible cystoscopy, so a camera put up through the urethra into the bladder, and they'll be looking at the joint, which is called the anastomosis, where they've done that surgery. And they'll get you to do all your pelvic floor muscles, and they'll go, oh, okay, yep, that looks good, or no, it doesn't look that great. The other thing they'll do is fill your bladder up with water with a catheter, and they pop another catheter in your bottom. And as they fill your bladder up, it comes on a big screen and you get tracing, and they'll see the pressures, and they want to see what your bladder's doing when it's under pressure. And after that test is when they decide what sort of surgical review that you need. So there is a simple one where they might just use medication to help with it. That typically works really well. The other one is, I think there's a couple of surgeons in Perth that do it. Can't remember what it's called, but I think it's like macroplastic or something like that, where they go in and they inject almost like a filler where your urethra is, and it pumps it up, and that can help with very small amount of incontinence. You've also got the sling, so bring my little friend out here, but basically the sling attaches to the pelvis, well, not the pelvis, the pubic bone, and it comes under the urethra and up, and that gives it a bit more support. So the sling is usually an overnight stay in hospital. You'll have a catheter overnight, and that'll come out the next morning. It can be very uncomfortable, so men can have quite significant pain for about 6 to 8 weeks, and then that'll settle, and that usually helps pretty well. But if it's very extreme urinary incontinence, then that's when they opt to put a artificial sphincter in. So that has a pump mechanic. I don't have one, but basically the pump sits in the scrotum, and then you've got a balloon that sits sort of in the abdominal area, and then there's like a little sort of clamp that goes around the urethra. And so there's always water in that little clamp. So when you want to have a wee, you basically press a little button in your scrotum, that opens it up, and then out comes the urine, and then it's got a minute timer or a 2-minute timer, I can't remember, and then the water fills and then it closes the clamp up again. So yes, there absolutely is help for permanent and persistent incontinence, definitely. And some men will be eligible for Surgical fixing after 6 months, especially if we know there is a shortened urethra already. But certainly after the 12-month mark, we want to get on top of it because it's a quality of life issue. We need to get this sorted. So yes, the other question, Katie, is too much pelvic exercise is bad?
It can be, yes. So if you think about all your muscles, okay, because your pelvic floor is like every other muscle in the body. If you went and ran a marathon when you haven't run a marathon before, what are your legs going to feel like afterwards? They're going to be pretty sore and tight. So if you do your pelvic floors too often and too much, you're essentially overworking it and it can become tense and sore. So then it doesn't function well. And I've had that happen often where guys are so keen, I'll do my exercises as much as I can because the more I do, the quicker I'll get rid of this leakage. Unfortunately, it doesn't work that way. And when we look at the pelvic floor research, the the research tells us 3 times a day is where we get the best sort of results. The research isn't brilliant, but it's there, okay? So that's what we work on, and I kind of tailor it to individuals. If you're doing too much and we're getting that tension and we're just not getting progress, I might even say to you, hey, let's just stop pelvic floors for a week and see if everything calms down, and then we can come back to it, but we're going to do it in a different way. And I do find that men think the harder I pull, the better it's going to be. But if you overwork that pelvic floor and start using your abdominals instead of the pelvic floor, then things aren't going to be great either. So,
Yeah.
yes, you definitely can overdo it.
All right, we've got two more, and then we'll let everyone run away. So another patient using an injectable. Should my erection last after climaxing? Another great question. So yes, we typically can see this. So you got to think when you're doing a penile injection, this medication's still working, and so we may still see an erection lasting that 30 to 60 minutes after you've actually climaxed. Some men get normal sort of erectile climax as you did before, so it'll come up, you'll use it, and then it'll slowly come down. But when it's lasting at a full erection for a time after using the injection, then you probably need to get in touch and see what's going on. But yeah, we do see some engorgement after climax. That is pretty common. And then one more for you again, Katie. So with the patient, I know he's asked me to ask you. So he has had his prostate removed a couple of years ago. He then unfortunately had some recurrence and had to have radiation treatment, and he's also had hormone treatment. So he's asking about, is it too late now in terms of his pelvic floor?
Look, in terms of pelvic floor and urethral sphincter, they're just muscles. So you can strengthen a muscle at any age, at any time of life. Um, it can be hard when, in terms of hormones, hormones will affect your muscle tone as well. So that's a consideration. And especially if you've had radiation, had radiation? Yeah. So when we have radiation, obviously we target, that particular area, whether it be the prostate or surrounding tissue, but the pelvic floor can get affected by that as well. And I like to think of it like a dish sponge. So when you have a new dish sponge that you bring out, it's nice and really pliable, and it bounces back really nice. But if that dish sponge got left in the sun for 3 days in summer, and then you got it, it's going to be all crusty. It's really hard to bend, and that's kind of like what happens to your tissues if it gets some of that radiation. So it makes it really hard for the pelvic floor to contract and relax properly. So the more we can move that pelvic floor, the better off you're going to be, okay? Obviously, the longer you've had the issue for, the more challenging it is to get there. However, there's every chance that you can. And as we said, if we can't get you fully continent with the pelvic floors after 6 to 12 months, and in your case, we probably wouldn't go to 12 months, but we'd be looking at other options to try and look at what supports we can offer you if you are medically able to have them. So it is a bit of a team decision and team effort in terms of talking to a pelvic floor physio, your urologist, and looking at all the different things we can put in place conservatively before we look at those any other options. But from a medical perspective, that would be one thing you've got to look at when we're looking at surgical options. Some people are just not able to have surgical options because from a health perspective, it's not appropriate. So yeah, it really depends on a lot of things, but pelvic floor training is a great place to start.
Yeah, great. All right, well, I don't want to hold up anyone else. So thank you so, so much, Katie, for joining me for the webinar. We've had some people already say thanks in the chat. Thank you everyone for joining us. The webinar will come out as an email if you want to re-watch it. And for those who have missed it, of course, you'll get an email. But thank you and have a good night, everyone.
Thanks, everyone.
See ya.